today I'll give you a lecture about practical uroradiology. The goal of this lecture is to gain you fundamental knowledge and skills about diagnostic imaging of urinary system by using or depending on using a different modality imaging like KUB, ultrasound, CT scan and MRI to get accurate diagnosis. This is our KNOS. Contents include lab investigation, radiological investigation, and anatomy of urinary system. The question is for you. What are the signs and symptoms that is suggesting urinary system investigation? Your voice? Loin pain? Immature, excellent.
Change in the color of the urine. Change in the color of the urine.
Change in color of the urine. Excellent.
Persistent urinary retention.
Urinary retention. Yes. This is the sign. Hematuria, urinary dysuria, frequency, urgency, incontinence, and retention of urine. The investigation. Which type of investigation we will do? First of all.
General urine.
Excellent. General urine. And this is include lab investigation. Yes. Include what? Lab investigation. Like general urine, CBC, regarding the urinary system. Serum uric acid, creatinine, albumin, blood urea, very important. And regarding the radiological investigation, that is our subject, KUB, ultrasound, contrast study, and CT scan. KUB, what the meaning of KUB? Excellent. How we can do it? How we can take KUB for the patient?
Supine.
Inside the X-ray department, there is a tray. We put the patient on it in a supine position, and the film extended from what to what? Below diaphragm until below symphysis pubis. Why? To include the whole of urinary system. And the question for you is, why we fasting the patient for 6 hours before? Why?
gastric
Yes.
الاير اللي موجود بالباول.
Gas of the
Gas.
bowel. To get rid of the gas of the bowel. We could see in KUB. First of all, started with the commonest stone. Yes. And no, it is a big mistake. Hydronephrosis is a dilatation in pelvic system. We can see it by KUB. I'll show you. I'll show you later. Another TB as what? As a what? TB, not as a lesion. As a calcification. So, generally, the KUB can see just the hyper-echoic, or echoic or radio-opaque lesion, which is called white structure. Any white structure, we can see it. Any other things cannot be seen. So, we can see stone, either renal, ureteric, urinary bladder stone, nephrocalcinosis, localized calcification due to TB and tumor, and prostatic calcification. And now, regarding these two images, who can explain this for me? At the left side, who can? X-ray, okay. The name of our subject, X-ray of what? KUB? Yes, KUB. Pelvic renal area. From where to where the kidney extended? From where to where? The level of the kidney, of renal shadow. D12, yes? L4. L4, excellent. So, from here to here, this is the shadow of renal area. And now we can say this is a radio-opaque lesion within the right renal area. The other slide, anyone can talk about it? There is no radio-opaque structure. Who is agree with me? Who is agree with me? There is no radio-opaque. There is no. Okay, you agree. Why there is no? And we put this structure, we called it double J stent. Radiolucent stone. This can be seen by ultrasound. So it is indicated for double J stent to make the urine pass. This is another type of stone, very large, hyper radio-opaque structure seen in the left renal area, suggestive for Staghorn stone. Is that here and there ureteric stone? In what slide? And how we can differentiate? How we can differentiate ureteric stone from renal stone?
دكتورة يوريتريك ستون because إنه راح تكون قريبة على السباينال كورد. لأن إذا كانت رينال فراح تكون away from spinal cord.
Normally, the kidneys from upper pole proximated to the spine and the lower poles get away from the spine. So, the more away hyper or radio-opaque lesion regarded as a renal, the more approximate, especially if it is passed over the transverse process of the vertebra, because this is the course of the ureter. So we confidently say it is ureteric stone. This is an example for vesical stone, large radio-opaque lesion or structure seen within the pelvic inlet, suggestive for urinary bladder stone. And now, I want to volunteer to explain the first image, another one for the second, and third one for the third image. Yes. Your name?
Ahmed.
Ahmed.
This is ultrasound image.
Excellent.
Show the kidney.
Yes. Which one? You can. It is
Right
not your
kidney.
job, but
Right kidney.
which
Right.
one? Right or left?
Right.
How you can?
From picture.
The liver. Look for this. This is the liver with biliary system or structures. Yes. Continue.
And with multiple focus.
First of all, we talk about what? Size. Yes.
Size of the kidney.
Yes. It is good, normal in size. Well defined or not? Well in size. Well in outline, well defined, and of a good size with. Continue with.
Multiple hyperechoic region.
Yes. Excellent. Because we use name echo in ultrasound. Hyperechoic lesions, multiple hyperechoic lesions seen within the parenchyma. The next image. Yes.
CT scan,
Yes.
sagittal view,
Sagittal?
corona.
Corona. Yes.
Show hypertense, multiple.
First of all, about the size. We talk about the size. Both are good in size and well defined and short.
And show hypertense,
Multiple bilateral hyperdense. Look for the name. Here we say hyperechoic. In the CT scan we say hyperdense. And then in X-ray, what we say? Radio-opaque lesion, multiple bilateral radio-opaque lesions seen within the renal areas in KUB. Yes, excellent. And next we discuss the ultrasound. How it is work? Anyone know?
Ultrasound?
Yes.
By sound wave.
Yes. How?
Vibratory waves, and
Yes.
also get signals by the transductor.
Yes, excellent. The apertures formed from two sections, the body and the probe. The body is the electric part, while the probe contain a small crystal known as piezoelectric crystals. This is when the electric beam hit it and emit sound wave. The sound wave goes directly toward the organs, and when hit it, reflected as an inquest. Return back where to the same crystal responsible for formation of images. This is the anatomy, is very important for you. I explain it for you. From outside to inside, the first layer is the capsule. Here, in the real image, it is lucent, which means the black in color. The next is the cortex or parenchyma. Then the pyramid and medulla. The more echogenic part in the center is the sinus. And then the root of the kidney, which include renal artery and veins and ureter. This is very important in grading of trauma. Be care about this anatomy. Yes. Who talk about these? Just this and below. Any idea? Anyone have idea? No? Okay. The first images show us right kidney of normal size, well defined, no stone, no hyperechoic structure, no hydronephrosis. Okay, this is a normal kidney in ultrasound. While this, look for this. Look for this. This is what we call it hydronephrosis. It's a collection of urine inside the renal pelvis due to obstruction, due to any cause. Not just the stone is responsible for obstruction. But here in our images, this is the hyperechoic structure regarded as a stone situated in pelvic-ureteric junction. Can you assess which degree of hydronephrosis? Can you? As such, hydronephrosis is a dilatation of pelvic calyceal system. If it is mild, there is no reduction in the parenchyma. Normal parenchyma thickness is between 20 to 22. So, if there is no reduction in the parenchymal thickness, it is a mild hydronephrosis. If there is a reduction in the parenchymal thickness below 18, it is regarded as moderate hydronephrosis, and this is due to chronic obstruction. While if it is the parenchyma, if it is very thin, we call it thin paper-like structure, this is due to long-standing obstruction, as this picture. And now this is the question for you, and you can answer me on this link. Which of the following regarded as the modality of choice for all type of urinary system stone? As your opinion. This is duty for you, homework. You want to answer? Ultrasound?
CT.
This is for you, homework. Which? What do you say? CT. Okay. Why CT? There is a limitation. Ultrasound can be KUB, cannot see the lucent stone. Ultrasound can see all type of stone, but it has a limitation. Small stone cannot be seen by ultrasound. Gas in the bowel, in the midurethral, cannot be seen by, prevent showing of urinary stone. But CT have a gold standard rule to see every type of urinary system stone. Who can explain the first image on the left side regarding the CT? We regard it as a standard golden rule in urinary system. Who can explain it? Last one. Yeah. Set. CT scan. CT scan. Sagittal. It is an anterior view. Coronal view, yes. Show regarding the left side, enlarged right kidney with mild hydronephrotic changes plus a hyperdense structure situated in upper ureteric part, suggestive for ureteric stone. Okay. The next.
And the well-defined margin of the kidney.
Yes, good size and slightly enlarged. The next one. We'll talk about it. I want you just to describe, not for now, not for diagnosis. CT scan, yes. With contrast, excellent. Show.
Coronal view,
First of all, we talk about the normal size.
normal size, but
Normal size, yes, it is normal
Right
size
side.
and well-defined left kidney.
atrophy kidney and calcification.
Which one, the right side? Yes.
Right side.
Atrophy,
size
do not give me the diagnosis, just explain, just describe.
Hyperdense.
Small,
hyperdense,
irregular, small,
small,
irregular outline, hyperdense, right kidney. Okay? Where's the parenchyma? Reduction in the parenchyma. And there is hyperdense, multiple hyperdense structures, full the organ, full the renal right kidney. And this is regarded as a TB. Now, we transported to contrast study. Like we have 4 types of contrast study. First of all, is the IVU urography, antegrade pyelogram, retrograde pyelogram, and vesicocystourethrogram. Do you know each one used for what? IVU indicated for what?
Renal artery stenosis.
Renal artery stenosis, obstruction,
congenital anomaly,
congenital anomaly.
Functional and
Excellent.
hydronephrosis.
This is the goal. It needs for function of the kidney. We have a phases of IVU, and this is to assess the function of the kidney, of the renal system. We will take a series of film. Why it is low osmolar and water soluble contrast? Why? Why? Yes. Why?
حتى يصير pass ويصير filtration.
Pass and easily to pass, yes. And
يعني
the exact cause. There is no hypersensitivity with this type of contrast media. So it is easily given to those with asthma, hypersensitive, any allergy, or chronic renal disease. This is the phases of IVU, which is nephrogram, should be done within 3 to 5 minutes to see what the parenchyma, here the function. And pyelogram within 15 minutes to see pelvic calyceal system. Yeah, the contrast should be passed through the calyces, pelvis, and ureter within 15 minutes. Lastly, cystogram, the bladder should be filled with contrast within 30 minutes. Contrast study. The name of investigation. IV contrast study. Yeah, short. Yes. First of all, normal excretion of the left side. Yes. The other side. What we call this delay. Okay, I say delay. This is a dense nephrogram. This is a dense, more wide right kidney regarded as dense nephrogram, suggestive of delayed excretion of contrast due to obstruction in the upper part of the right ureter. Here, look for the dilatation of the ureter. Yes, yes. Some congenital anomaly of pelvic calyceal system. Can you explain this? This is duplication of pelvic calyceal system. It is maybe just included the calyces or calyceal and upper ureter, or maybe extended down to involve the whole of the left ureter. What is structure? This is circular hyperdense structure. Look, the stone is white, so we can see it in a plain X-ray, KUB. But the IVU, the contrast is a white. If it is passed and the stone also white, you cannot see the stone. So the IVU study just foreseeing level of obstruction or congenital anomaly like this. This is cobra head. It is cystic dilatation of the lower ureter. This is the other type of contrast study. Integrate pyelogram, which is direct injection of contrast media through the kidney by nephrostomy tube. The other is retrograde pyelogram, by passing the catheter through the urethra and then pass the lower third sphincter and then giving the dye. My question is, why you use this type of contrast study? Why? And for what we use it? Should be different. Why we use it? If what? Main indication, the main maybe, but the main indication is when the IVU not informative. So we go to integrate pyelogram, the direct study, integrate pyelogram and retrograde pyelogram. And this is, the IVU is for function, because the dye passes through the blood and then to the tissue to measure the function of the kidney, while this is just for anatomical purposes, because it is direct injection to the passages. Another congenital anomaly, we call it horseshoe kidneys. Can you explain or describe it? CT scan. CT scan. The first one, which section? Coronal. The second one, is this contrast or not? Contrast. Here it is very clear. And there, why we say it is contrast? The aorta, arterial face, yes, excellent. The aorta. Show us union of both lower poles in front of the spine. Crossed, fused, ectopia. Explain it. This is IVU study. Show us both renal pelvis with ureters in the right side. So we call it crossed, fused, ectopic. The upper pole of the crossed one union with the lower pole of the original one. And here is the PUJ obstruction. How many constriction we have in the ureter? Three. The upper one, pelvic-ureteric junction, and the mid one. And the third one is the uretero-vesical-ureteric junction. And here, as I said before, the IV study is just for obstruction, not for detection of a stone. Because the obstruction occurred due to many causes like this, made physiological, ganglionic segment, stone, mass, accessory renal artery. What is the type of examination? That is different from the others. Vesico-systole or voiding systole ureterogram. That is indicated for reflex uropathy. So, we inject it from below, from the urethra. Look for the catheter here, and it's pass because the sphincters are loose. So, what the important question we ask the patient to do is ask him to
Not voiding.
to voiding, yes, to void. If it is stay like this, on voiding and then take an image. If it is stay like this, it is regarded as reflexio bilateral reflexuropathy. But if it is returned normal to its normal situation, there is no reflex. This is for you to describe. It is what the type of study? CT scan. Which is section? Axial, excellent. At which level? What these hyperdense structures? Iliac crest. By the toe. Conclusion. I help you. This is arena, kidney, inside the pelvis. So it is ectopic, pelvic, kidney. This, who describe it for me?
This is a CT with contrast.
Excellent.
Axial
Section.
section.
Excellent. Show us.
So the kidney, the left kidney.
This is the right. This is the right. Always we can read it opposite to our hands. And the liver, part of the liver appear here. Another sign is that this is the aorta on the left side, and this is the IVC in the right side. So 3 signs: IVC, liver, and your direction, your body direction. Okay, yes.
This is the right kidney.
Right kidney. Excellent. Short. Well defined.
Well defined. Margin.
Hypo or hyperdense? Hypodense lesion. Yani this is lesion is not taking a contrast, so it is a benign, and regarded as go explain for this.
Abdominal CT scan.
Yes.
Axial section.
Yes.
Large kidney.
Both axial and coronal section.
Bilateral polycystic lesion.
Bilateral, not polycystic. Not use the name of the lesion. Just say with multiple bilateral small cystic lesion. This is the description, not the diagnosis. Yes, continue. Not enhanced. The cyst is always not enhanced. Any benign lesion, not enhanced. Not enhanced, suggestive for polycystic. Another indication in this image indicate us for polycystic, yes, liver lesion. Also, because it is a systemic disease. This is another image for the same pathology. What's this? CT scan. Axial or coronal? Axial. At which level? Pelvic. This is the iliac crest. Short, multiple, hyperdense foci within the urinary bladder, such as vesicle. And now we will take the anatomy and degrading the trauma of the kidney. Yes. First of all, if the hematoma involving the capsule, regarded as a grade 1. If take the capsule and the parenchyma, grade 2. If it is descended to involve the pyramid, 3 layers, capsules, cortex, and pyramids, the third. If it is reached the sinus, 4th grade, and if it is involved the vessels, the root, it is a grade 5. So, the next question. This is which grade? Involve capsule, parenchyma, pyramid, and venous sinus, yes. Grade 4, excellent. This is which grade? 3, excellent. Involving the capsule, parenchyma, and part of the pyramid. And now we transport for ultrasound to show this is a tumor. Anyone can describe it for me? Urinary bladder tumor. I'll describe it for you. It is a urinary bladder section, so show us a regular outline, hyperechoic mass seated on the left lateral wall of the urinary bladder. It is suggestive for tumor, mass, and clots. The next question, how we can differentiate between the two?
By movement?
Yes.
If movement,
How
clot,
we-
if not movement, mass.
If it is moved, we can upside down the patient. If the mass moved, it is a clot. If not, it is fixed, it is a tumor mass. And this is, look for this, this is another lesion within the urinary bladder involving the wall, appear irregular, and involving the lateral wall and lower ureter. It is also ureteral tumor. This is male ureter. You should know about the anatomy. It is involved 4 parts. The prostatic part, membranous is the narrowest part, bulbous part, and penile part. And your rule is just detect the side of structure. And here, can you tell me what is the normal and what is the abnormal? The first section is normal. The second one, and the penile part, there is a structure, narrowing of the lumen. This is study known as Hysterosalpingogram. Can you explain for me? This is a spillage. All of it due to patency of the left tube. This one, there is no spillage. It is suggested for bilateral, no spillage, distal dilatation of both tubes, suggested for bilateral tubal obstruction. This is the anomaly of the uterine cavity, you know about it? Yes. The two important anomaly is the septated one and bicarnoated one. How we can differentiate between them? Simply, we can see the dome of the uterus. If it is intact, convex, with a line descended downward like this, it is a septated uterus. But if the dome of the uterus take a concave shape from outside with this curve, it is a bicarnoated uterus. And now, what's this? Septated Y. Keep it is done. No bifurcation from outside. Sorry. This is why? Dome of the uterus divided from outside into two uterine body. Two uterine body from outside. This is the image looked at for you. The above image is a case study for you. Required report. Send it to me on this link. Write type of study. Describe the image and the diagnosis. Summary. You know, practical uroradiology is very important, play very important role in diagnosing of urinary tract disorder, infection, tumors by using a different type of imaging modality to get what? Accurate diagnosis. This is your homework, a question for you. And then thank you for your attention and participation. I hope to get more discussion and shared learning in future. Thank you for you. This, who is the volunteer? This is a question for you, I think. Yalla. What is the type of study? This is MRI. Which study? T1, T2? Which one? T2. Why? Why? Assam? You have no idea? Any fluid can appear hyperintense in T2 and appear signal void and lucent in T1. So here, the endometrium, very rich with blood vessels, so it is appear as hyperdense structure, hyperintense. So, and now we are with MRI of pelvic region, T2, T-weighted 2, show us what show? Why bicarnoated?
Separated.
The dumb what? Look for the dumb. Look for the dumb. Is it preserved or not?
No.
The dumb.
Preserved.
And the septa is descending downward from the preserved dumb. So it is a type of septated uterus. Can anyone explain this for me also? Which the type, what the type of investigation? Transvaginal. transvaginal ultrasound.
ultrasound.
Show us.
شاف septate uterus.
Describe first to reach to the diagnosis.
شاف uterus. septate uterus. Endometrium.
I want a description.
And the dome of uterus is above of the septum. Above.
The dumb. This
And
has
the-
4D
Yes.
transvaginal ultrasound. Show us uterine cavity with intact fundus and a septa descending from upper part of the uterus down to its cavity, suggested for septate.
Septate.
What is this finding? It is separate the cavity into two parts, but not uterine body, just the cavity. What is this?
Most likely adnexal mass.
Inside the uterus.
Yes.
Yes, excellent. This is an incidental finding, pregnant woman. Sac, gestational sac. This is a small, yes, gestational sac. What is the difference between the didylphus uterus and bicornuated uterus? This is a question for you. How we can differentiate between the didylphus vagina and
Complete.
maybe bicornuated also complete. Both of them contain two uterine body and two uterine cavity, but bicornuated have intact single cervix, while the didylphus contain two separated cervix. No, not two vagina. There is no anomaly of two vagina. Just one, but the cervix is two. Okay? This is the tunnel of the vagina. Inside it, there are two cervix. If you see two cervix, it is the didylphus. What the indication of hysterosaline salpingography? Fertility, yes.
Sugar damage or sugar obstruction.
Yes. Anomaly, adhesion. How can we differentiate between the zygocystoid graft and integrate pyelogram with retrograde pyelogram? How to differentiate between these two investigations? Which is the indicator?
nephrostomy tube.
Nephrostomy tube. In which investigation?
الانتيجويد.
Integrate. And this? Where's the catheter? Where's the tube? And can you differentiate it from, look for this, just a minute. Look, take a look, and then look for this. How you can differentiate between voiding cystourethrogram and retrograde pyelogram? How? This hysteroretrograph is done through the urethra. Look, by catheter. To show The aim of the study is to show this sphincter worked or not. So the dye should be put in the vesical part and urethric part up to the renal system. But look for the retrograde. There is no catheter here because it is passed. It's a procedure should be passed over the lower third sphincter and then give the dye. So that is the difference. The integrate show us nephrostomy tube. The retrograde, there is no tube because it's passed and its head filled with contrast study. While the voiding cystourethrogram show a catheter. And thank you for all.